today what we're going to be doing, my name is Dr. Coltrider, and hopefully this kind of video gets to you and you kind of take an idea of what we need to be doing and kind of the background of why we're teaching this and the importance of it, and just kind of going through splinting is really the big meat of this topic today, okay? So it's going to be primarily for providers, but also for PCTs and back staff that are going to be watching this as well. So what I tell everybody when we first start doing splinting or something like that is just kind of familiarize yourself with the materials. So obviously you can see I'm holding two things right here. One of them is going to be this padding, okay? So that's going to be the comfort level of the patient. The other thing is going to be, and there's many different forms of this, but this is going to be the ACE wrap. Okay, so we'll get to these when we talk about them. The last thing we talk about, as far as actual materials you have in your hand, what we have here is going to be this ortho glasses casting roll, okay? And then big things that I talk about is knowing your materials, knowing which splints to do where, and we're going to have a kind of a separate kind of reference for you or a sheet for you to look at when we know, okay, well, what splint should I do that? Some people keep it in their heads, and then other people just kind of have to look it up each time. It just depends on your comfort level of A, doing splinting, and B, also the fact that if you've done a lot of splints, you remember them and things like that. So basically what I tell everybody is a lot of our splinting is going to be upper extremities. A lot of the lower extremity stuff we probably won't have much in this video, simply because all of it is kind of prefab at this point. You're going to have your walking boots, you're going to have your crutches, and then you're also going to throw in there, hard-soled shoes, like post-op shoes and things like that. So most of the stuff when we're doing lower extremity is all going to be kind of prefab stuff. We're not really going to have to do too many splints for that. But the bigger thing is going to be the upper extremities. So we're going to do a lot of talking about those kind of splints and how we deal with them and what we do. There's a couple caveats to all of this, but one of the bigger things is pre and post exams, so not only for documentation purposes, but also for what we need to know and what we need to be able to teach our back staff, okay? So before you're doing either, some sort of splint, whether it be because we had an open fracture, if we just had, a regular broken bone, whatever it may be that they came in for, really honestly what you want to make sure of is that before you do anything, including numbing them up for possible pain control, because sometimes, you'll have a hematoma block or something like that, the biggest thing you want to make sure of that we're doing is that we have a good sensation exam before we do any kind of numbing or anesthetic or anything for pain control, and then also a good range of motion and joint function, okay? So if we're talking about in a hand, you're going to need to test each joint in isolation. So if you're looking at this finger, we've got 3 separate joints here. So here, here, and here, okay? So we need to make sure pre-splinting we do that, and post-splinting we do that. And the post is going to be pretty important. If you're not the one putting on the splint, then you're going to want to be the one that goes into that room, and you're going to have to test, make sure that A, did the splint right, and B, did we have a good examination? Is it too tight? Is it too loose? You don't want to have somebody have like ischemic digits. You don't want to have somebody that has it too loose that it just falls off. So then you're kind of shooting yourself in the foot. So if it's not done right the first time, it's kind of a problem. The second caveat that I always bring up with splinting is to make sure that we're not over splinting. All right, there's some things that need splinted, there's some things that need immobilized, and there's some that really don't. So we don't want to do the least amount of immobilization as possible that will still achieve our results. Now, what does that mean? The biggest thing that I tell people is a good for instance is tuft fractures of our fingers, okay? And I used to be the worst at this. I always used to go overboard. If you have a tuft fracture of a finger, there's no need to put on a full finger splint, because then you've got 2 other joints that you've now mobilized, and it's going to be harder for them to get back that range of motion that they had before. So what you do is you make sure the least amount that you can, the least amount splinted is what you should do. A tuft fracture, just put on one of those little plastic pieces, okay? Then they have the rest of their finger to move, and they can use the rest of the joints except for the part that's broken, okay? And that's going to go for the rest of the finger as well. So there's the tuft one up here. When you're getting back in here, that's going to be a full finger splint, okay? Just because even though you are getting a little immobilization here, but really honestly, you just need to make sure that that finger's not moving, and a full one will be okay, okay? That's kind of the least amount you could splint a finger. That's not going to keep it it's going to keep the other fingers still working, okay? Now when you're getting down here into the hand, okay, down into this part, the carpals, metacarpals, and things like that, we're obviously then going to need to probably immobilize a lot more than just that. So that's when we fall into doing our things like the ulnar gutters, the radial gutters, and things like that, and we kind of go over that. So what I tell everybody is those are kind of the caveats. We remember what we need to test before, we need to test after, so we talked about that. The next thing is just kind of getting to the nitty-gritty of actually doing the splints. So I tell people, we familiarize ourselves with the materials, then let's go forward and kind of take a look at it. So we know that when we put a splint on there, it's going to be A, uncomfortable, it's going to be B, a little tight because we are immobilizing something, and C, what you have to remember with this ortho glass that we have is it is an exothermic reaction, so it is going to heat up. So you can burn patients, you can hurt patients with that, okay? So that's why I say that this padding is important. You're always gonna wanna be using this padding on the areas in question. So, I mean, honestly, what you wanna do is make sure it's wrapped where it is. You need a couple, and then we'll go over the resources of how much to use with this. But honestly, 2 little layers like that, you'll see how thick it starts getting. And so it's gonna be, you really don't need all that much, okay? So you're not needing like 10 of these layers. Now, when we get to the orthoglass, we're talking about using probably 8 to 10 layers, 12 to 14, it just depends. You're gonna need that thicker, okay? But with this padding itself, you don't need all that much. This is just for the comfort level of patients. Now, what I see people forgetting, and one of the things that's easy to forget, and that's why I kind of bring it up with the video here, is once we put this padding on here, you wanna make sure it's padding between all the places. So if we're doing like a thumb spiker or something, or if we're doing a finger and we're trying to immobilize something like on one of the joints, if you're immobilizing this finger and you're gonna put on, say, a radial gutter or an ulnar gutter, don't forget the web spaces in between where that casting is, and put a little padding there, or in between the toes. If you forget that, you can have a big ulcer that comes in, so when you take off that splint or that cast or whatever, it might be that you put on there, you'll see a big old ulcer or a wound that now you have a problem that you didn't know. Okay, so now you've dealt, more of a problem. Same thing along the lines of if you immobilize too much. Now, if you say you immobilize something that didn't really need to be immobilized as much as it was, and say they missed, having a follow-up or something, they didn't get to see the orthopedic guy, well, now they get there and they've been in an ulnar gutter for, a month, 2 months, 3 months where they shouldn't have been, and now they're either on a really long road for recovery with rehab, or that ortho guy is gonna not even touch them and they just now have lost function. So if you don't ensure that you're doing these right, you can cause a lot of harm. So sometimes it's better to kind of say, hey, maybe I need to take a step back. Maybe I need to know what I'm doing more than just kind of, just winging it and throwing it on there. Okay, so you can cause a lot of harm with these. And that's kind of the main kind of backstory of the splints and kind of what we should do, what we should think about. Those are the pre and post exams. That's the materials that we talk about. The next thing is kind of getting more into the nitty gritty of remembering to do these things and remembering to tell our back staff. With this, anytime we measure it, you always want to measure twice, cut once. That's going to be always a thing, whether you're in, building houses or if you're building splints, it's the same thing. So make sure with this ortho glass that we have here, that this clip is going to be in our clinic, and everybody should remember about this clip because these boxes are pretty expensive, okay? So if this clip is not at the furthest point that's actually like open, so for instance, when you're cutting this, you can easily make a hole here or here. If you don't have that clip at that farthest most hole where you made it, it's going to be open to air, and air is the agent that's going to cause this to start heating up. So you'll waste this whole box of stuff just because you forgot to put the little clip on there. All our back staff should know that, but it's just something to remember and to keep in our heads, okay? Make sure that goes on there. Now, I would point to our kind of our reference sheet that we were talking about. So really the biggest thing is upper extremities are going to be about 10 to 12 layers. So that's what we talk about there. You always want to measure it. And one of the things that I tell everybody is when you do measure it and you do cut it, make sure you actually cut a little bit longer than you'd want to, because if you cut it too short, you have to start the whole thing over. Okay, so if you get it the perfect size, you still may have a little bit that you've missed. So if you make it just a little bit longer of where we were before, then you're gonna have enough that you can play around with it just a little bit. Now I'm not saying making it 2 times as long as it should be, but just having a little extra there so you can play with it, and when it, you get it wet and everything, it kind of shrinks up a little bit. You'll be able to kind of better see how it fits on your arm or your finger or wherever it might be, okay? The other things that are kind of, don't forget to think about these things is when we wrap it, we always want to wrap towards the heart. Okay, you never want to wrap anything away from the heart, especially if it's really swollen from the injury. So if they just came in just after the injury, okay, it's going to be super swollen. You have problems there even getting a good fit. So sometimes you put a cast or a splint on them. The correct term should be splint. I say cast just because some people use them interchangeably, but splint is what we're actually doing, not casting. But with the splint, some days you'll put it on and it'll be a great fit then. And then the next day or a day after, they'll say, hey doc, my cast is just sliding off. Probably because that swelling went down and now it's not as good. So you might have to bring them back in and redo the splint just because their swelling went down and stuff like that. But the big thing here, like we're talking about, wrap towards the heart, never away from the heart. You don't want to trap any blood, any fluid, or anything like that in the actual extremity. So it's just a good idea, especially with the ACE wrap, but also with this padding. So when you wrap it, you want to wrap it towards that heart. If this is real swollen and has a lot of blood in there or something, or if it's just edematous from the soft tissues, that squeezing and that kind of pushing it back along the lines of the return that it should be anyway is how you want to have it. So feet up towards the heart, arms towards the heart. The next thing I tell people is with this ace wrap, it is very kind of pliable. You can bend it and pull it a lot. You don't want to stretch this a lot. Okay, that's one of the bigger mistakes. Is the first one I saw, for instance, wrapping this down instead of wrapping it up like we talked about. And the next big thing that I talk with people about is when we put this on, we're not wanting to pull it real tight and going around. What we want to do is just lay it down. So really honestly, when we put this on, we just want to lay it down here. And you just lay it along the lines of wherever you want to have it. Instead of pulling it tight, you just kind of lay it on it. And that's going to be a lot better. Okay, that's going to have a lot better with your splint, and it's also not going to cause that pressure on it and making it feel too tight. If you pull that really tight, the patient's going to sit there and go, ow, this hurts, you're going to have to redo it. And so you really just don't want to have to redo it, and that's one of the big things that can cause us to have to do that. Plus, the tighter you pull this, the harder it is to get kind of like a neurovascular exam. And that's one of the bigger things with the ace wrap and pulling it really tight. The next thing I said, we already talked about the exothermic reaction, we talked about how it's going to heat up, but what we didn't talk about is with the actual material itself, it's going to matter what the water temperature is. It's not the biggest a deal, but if you're going to make that water really cold, so if it's cold water you pour it on there, you better be really good and really fast, because that's going to harden up really quickly, okay? It actually speeds up the exothermic reaction and causes it to cure faster. If you just leave it out to air, it'll probably get hard in the next several hours, but it's going to take a lot longer, okay? So if what you want to do is just kind of lukewarm water, and once you have that lukewarm water, you put it in there, and obviously we'll have a demonstration of what it looks like, but you put that lukewarm water in there, and then after that, you kind of make sure that once it's there, you don't let it get too cold, don't want it to be too hot, and then once you do that, you wrap it around it, and then that should make the plaster solidify or get hard in a reasonable amount of time. But that's kind of the basics. Like I said, you start with the padding, then you put on the orthoglass, another wrap of padding, and then the ace wrap. And that's the basics of all your splinting that we're going to do. So I think the next thing that'd be more helpful is kind of going into the actual splints and talking about those, and less talking about the materials at this point.